So we'll start with the first talk, and it is Prof. Michael Gnant from Vienna in Austria. Michael, the next 20 minutes, half an hour is all yours.
Oh, thank you very much, Yazan. Thanks for the invitation, for the very kind invitation to the iBreastBook highlights of congresses. And it's my pleasure and honor to tell our audience a little bit about the 17th St. Gallen in Vienna breast cancer conference, which in fact, as so many conferences, could not take place face-to-face, but needed to be transferred to the virtual world. Here are my disclosures, a few images of the beautiful city of Vienna. And this, on the right side, you can see actually the only single one Congress badge that was produced, because I insisted that we would have something like that for historical reasons, because unfortunately all the other participants had to be online. However, that really didn't make much of a difference. It even had a number of advantages. For example, outreach could be greatly increased, as you can see. Expectedly, the majority of attendees from Europe, but very significant contribution by Asia, North America, South America, even Africa. And you can see that's not only the Central European countries that traditionally make up the majority of the audience, but also China, but even Argentina, Saudi Arabia, Japan. So it was actually 3,500 people actively participating, because the virtual format also gave us the opportunity to do this really more interactive. So the audience was able for the first time to propose questions to the panel. But in addition to this, there was also live discussions, not only after each state-of-the-art lecture, but also during the consensus sessions, which for that reason were split into two parts and to 2 days in order to accommodate everybody from the American West Coast to Japan, which obviously is also a time zone issue. And there's a few images here, as you can see, quite some prominent figures, including the ESCO president moderating the consensus panel. So that is some images, and fortunately the majority of people were really satisfied, and we got a lot of input, including keep that format also virtual in the future, even when it will be possible to travel to Vienna and to convene in person again. This is a very important slide, and I'm putting it here because, the consensus, the St. Gallen consensus has a certain format that one needs to understand. This is not an evidence-based process, it's an opinion-based process. And I think that's okay, as long as you keep in mind that this is the case. Also, when we vote on clinical situations, and there were more than 140 clinical situations where votes were asked for, questions were asked about, the answers should apply to, let's say, the average or to the vast majority of cases. So very clearly, if the panel states with 100% yes, you should do, I don't know, neoadjuvant chemotherapy in triple-negative breast cancer, then that does not mean that nobody could envision one single patient with certain cardiac or other issues for whom that might not be the individually optimal decision. So it is for the decisions and recommendations of the St. Gallen consensus panel are for the majority of patients. Here you can see the lineup of a total of 73 specialists who contributed to this, and the questions and answers I'm going to show you exemplarily have been answered by them. We managed to do some rotation, although that's very difficult. Please do not use these slides for direct reference, because without interpretation and some discussions, some of the votings may not be perfectly clear. The Annals of Oncology manuscript about this is appearing very soon, so please refer to that if you need to really quote or reference the St. Gallen consensus of 2021. Also, what I'm going to show you is a personal selection of what I consider important, or maybe surprising, or maybe revolutionary in terms that previous St. Gallen consensus have decided that differently. And here comes the first revolution, I think, in terms of surgery. The question was, in women with ipsilateral breast cancer recurrence and or second primary breast cancer, is breast conservation, meaning another breast conservation, including re-irradiation, an appropriate option compared to mastectomy? And as you can see, the answer to this was yes. And why do I call this revolutionary? It's not that we all might not have done this in the past already, but when you look at the textbook knowledge or at all the current guidelines, they still call for mastectomy in case of local regional recurrence. And St. Gallen for the first time endorsed, well, go ahead, if this is possible, observing the rules of surgical oncology, radicality, and principles, then you can do another breast conservation, particularly, obviously, if the biology is favorable, like small tumor or luminal A tumor, but that's biology nowadays actually more or less impacts on all our decisions. Another question, because many people play around with that, and we can have a nice controversy about this: can we totally omit surgery in cases of clinical and radiological complete response or remission after neoadjuvant systemic treatment? And as you can see, a clear-cut no, or never, not even if you prove or try to prove that by PCR. That's clinical research. There are some trials running. Personally, I'm not convinced that this is the most important question for women, but in fact, at least the state of the art is, well, we are not going to omit surgery. Another rather technical issue, so that's mainly for the surgeons. There were some quite technical questions this time in the St. Gallen consensus. Should the intercostal brachial nerves be preserved when possible in the standards of the surgical technique? And in fact, the question was a very clear yes. So that makes it a little bit more technically complicated and may add a few minutes to the usual procedure time. So we might be able to discuss this. Next surgical question. In women with ipsilateral breast cancer recurrence and negative nodes, the preferred management of the axilla is, and then you can see that's a split panel. No further axillary section. That was said by a fifth of the panelists. Sentinel node procedure with or without frozen section, 2/3 of the panelists. And some even advocated complete axillary lymph node dissection if you have to go there another time in case of local recurrence. A big issue that is controversially discussed nowadays is, what are we going to do with the axilla after neoadjuvant therapy? And one of the questions, how it was phrased, was, is axillary dissection always indicated when there is residual cancer in the sentinel lymph nodes, meaning, in this question, macrometastases? And the answer with 75% here is yes. That means axillary dissection. Obviously, when there is individual tumor cells or micrometastases, the answers will be different. Probably the most provoking new vote in the St. Gallen consensus was about radiotherapy. Moderately hypofractional treatment, so that's usually something like 2 to 2.5 weeks, is appropriate for women receiving. And now you can see post-mastectomy radiation, where so far this was really not permitted, 90%. So in essence, the St. Gallen consensus panel in 21 said you can use hypofractionation for every situation of breast oncology. I apologize. So that includes regional nodal irradiation, for example. 3 out of 4 panelists said, yes, you can still do that. And when you think about, how many resources around the globe are taken up by unnecessary radiotherapy for 30 days, I think that's quite an important information, that these experts in the year 21 said, no, you don't have to do that. 16 days is good enough for almost every situation of breast irradiation. Quite a significant change. Now, breast, that may be a little bit too much detail. So that's more or less just underlining what I have just said. Regional nodal irradiation, is that indicated in patients with triple negative breast cancer if the nodes are negative and they get post-mastectomy radiotherapy? Should then be the nodes irradiated in addition? 80% said no, don't do that. If the nodes are negative, don't irradiate them. Even more so in situations of luminal breast cancer. Again, node negative disease, post-mastectomy radiotherapy, don't do nodal irradiation there. Another issue that we keep discussing controversially now, I think since decades, is radiotherapy in the elderly. Can we omit radiotherapy? I'm not sure it's okay to call everybody above the age of 70 elderly, but that has to do with my own growing age, that I think we all tend to shift the elderly order up while we age. Anyway, should we omit radiotherapy in patients with large tumors if they are node negative just based on age? Clear-cut answer, no, don't do that. If they have a positive sentinel node, clear answer, no, don't do that. Next issue is adjuvant therapy. And, consensus doesn't always mean that there is consensus among the consensus panelists. And here you see an example. The question on what is a ER positive breast cancer, and it has been discussed for ages as well. Should the cutoff be 1% or 10% of ER positively staining cells? And exactly 50% of the panelists said 1%, and the other 50% says 10%. So no resolution for this. Another question for pathology. Would the panelists usually accept that if Ki67 is high, meaning 30% or more, then adjuvant chemotherapy should be proposed to this given patient? And if the Ki67 is very low, less than 5%, no chemotherapy should be applied. 2/3 of panelists say, well, yes, that's an appropriate guidance. However, it's a little bit more difficult in the details. Another subject, DCIS. In women considering endocrine therapy to prevent recurrence of DCIS after surgery and radiotherapy, the preferred treatment is, and now you can see that there is tamoxifen, low-dose tamoxifen, aromatase inhibitor, but the message of this vote is that with a clear-cut majority, the panelists say, well, yes, do that. Offer endocrine treatment to patients, irrespective of the fact that most studies, in fact, don't show an overall survival benefit, but the advantages outweigh the disadvantages, always given that there is a reasonable tolerability in individual patients. Very interesting way to ask this time, what would be the size threshold for initiating any adjuvant therapy in node-negative breast cancer according to subtype? And here you can see for luminal B, the panelists said the threshold, in fact, is less than 1 millimeter. So 60% said even if the disease is microinvasive, if it's luminal B, then this patient needs adjuvant therapy. If it's an ER positive HER2 overexpressing disease, the threshold is somewhere around 5 millimeters. So we are still not treating the T1A, at least the majority of us, but beginning at T1B, this patient should have systemic therapy. And I think that could also cause some discussion. If the situation is HER2 overexpressing but ER positive, ER negative, I'm sorry, then as you can see, the majorities even shift to lower size thresholds here. So many panelists believe that even in the situation of receptor negative HER2 overexpressing breast cancer, that even at 3 or 2 millimeter size, adjuvant treatment should be applied, because with the clear-cut intention to offer the anti-HER2 treatments that we now have so wonderfully to the majority of patients. Obviously, that goes down, as I've said, with the receptor negativity. And when do we start considering systemic treatment, which means mainly cytotoxic chemotherapy in the adjuvant situation for triple negative breast cancer? And again, you can see that magical 5 millimeters. So yes, treat T1B tumors, and maybe the PT1A can get away without adjuvant treatment. Another very controversial issue is obviously as studied in trials such as TAILOR-X, MINDEX, RxPonder, if you have a postmenopausal patient with a low risk signature recurrence score of 25 or below, so that's not exactly low in the oncotype, should these patients receive chemotherapy? And the clear majority said no, don't give, stop, finally stop over-treating these patients. So these patients do not need adjuvant chemotherapy. About modern and innovative approaches, should patients with stage 2 or 3 triple negative breast cancer not treated in the neoadjuvant setting, what they should have been, I might personally add, receive adjuvant immunotherapy with a checkpoint inhibitor? And the clear-cut answer is no, that's not ready for prime time. 90% said no. Should we test all triple negative breast cancers for the expression of PD-1 or PD-L1? And once more, the panel, rather conservative, said no, that's not ready for prime time. You don't have to test because we don't have an evidence-based answer to that. To the contrary, and that was quite controversial 2 years ago, should all patients with triple negative breast cancer and residual disease after standard neoadjuvant treatment, residual disease at the time of surgery, I should add, be offered adjuvant capecitabine? You remember that basically the CREATE-X, an Asian study, proposed this for the first time, recently updated with a 5 to 6 year overall survival benefit in long-term follow-up. And this has now arrived in clinical practice. Yes, almost 90% of panelists said, yes, you should do that. Use post-surgical capecitabine for these patients. As I've already said, consensus doesn't always mean consensus. So some of the issues have been unresolved. Is there enough data to justify prophylactic mastectomy in breast cancer patients with a PALB2 mutation? 50% say yes, 50% say no. So I think that's a moving target. Most of us would agree probably for BRCA1 and BRCA2, and many of us would say that the PALB2 should be upgraded to this, but others are not so sure. I think reflecting very recent discussions we have after recent scientific publications. Can we omit radiotherapy after breast implant in the DCIS with adequate margins if the patient is 70 years or older? A very light majority says yes, but that's far from consensus. So obviously other factors are in there. Premenopausal patients, very interesting question. What is the likely contribution of chemotherapy-induced ovarian suppression to the effectiveness of adjuvant chemotherapy? Basically addressing the question that eventually how many of the receptor-positive young patients will need chemotherapy, or is adjuvant chemotherapy just the more toxic way to do ovarian function suppression, like we can do more elegantly with LHRH analogs for example. And you can see that the panel is very split here. It may also depict the transatlantic split of the panel, but the majority of about 65, so 2 out of 3 panelists say at least 50%. Some even 75%, and some even all of the chemotherapy effect is in fact indirect endocrine treatment. Probably that's not true, but the majority at least believes that the cytotoxic effect of that, in addition to the ovarian function suppression, depending on patient profile, obviously contributes largely to the effect of adjuvant chemotherapy. Another controversial issue: how long should node-positive breast cancers, if they are luminal, ER positive, HER2 negative, what is the optimal duration of treatment? 5 years, only 11%, 7 to 8 years, 34%, 10 years, 52% of the panelists. I should say, with rather weak data, you will see very soon in coming weeks a large trial I was able to lead with 10-year follow-up that will address this question. So watch out for some of the more prominent medical journals to see that study, ABCSG 16. Should patients with ER positive cancers and 4 or more positive nodes receive an adjuvant CDK4/6 inhibitor? Abemaciclib, following the Monarch E data, you see split panel, 50% yes, 50% no. So that may not be ready for prime time at this point in time. And should patients receiving neoadjuvant chemotherapy also receive platinum? The platinum question is as old as breast cancer systemic treatment. And once more, it was a split panel of whether platinum is necessary or platinum should be used. And as sometimes I might add personally with medical oncologists, they can argue forever about different chemotherapy regimens. You know, what is the optimal regimen? Is it TC? Is it AC, EC? Is it AC, EC followed by T? 3 cycles, 6 cycles, 8 cycles. You see that everything is there. No clear-cut consensus of what is the adjuvant, optimal adjuvant treatment. In closing, another, I think, very interesting issue that was there for discussion for the first time, that's oligometastatic disease, and very interesting voting results. A patient with a clinical stage 2 N1 breast cancer and an isolated metastasis in the sternum, would you recommend the following? And in fact, the majority of panelists chose proceed with curative intent. So that's very, very new. In any textbook, you say if there is metastasis, then we are in a palliative situation, and there might be exceptions to that. The panel for this time, and not everyone might agree, stated that, well, if there is limited metastatic disease with all the wonderful achievements we have in multidisciplinary breast cancer treatment, let's go for cure. And I find that quite interesting. It may be very optimistic. It may not be mature for textbook knowledge, but at least it's indicating, I would say, a spirit that we are extending our quest for cure into at least the early metastatic disease, as you can see by another vote to this subject. And only after, you know, really multiple metastases, so that's more than 3, then the traditional view of, okay, that's now a palliative situation, only treat for local regional control, and forget about cure in that situation. So I think that's an interesting indication of where the field goes. Finally, one question, obviously, COVID was dominating the last year for most of our lives, and the panel said, should vaccination be offered to all women before chemotherapy? And the clear-cut majority gave the message, yes, please have these patients vaccinated. So hopefully we can be rather quick in vaccinating anybody around the world, but obviously breast cancer patients are a certain population at risk. It may be less clear for those who had recently completed chemotherapy or, you know, with newly diagnosed breast cancer. Definitely the panel was in agreement that all caregivers should be vaccinated as quickly as possible, which I think we also all would agree. With that, we'll finish my summary of the St. Gallen consensus, this time virtual, so only virtually in Vienna, but still with some provocative thoughts. And I will close with an invitation to join the St. Gallen conference in 2023, together with some of our discussants today, including Bahadir, who will be there, and hopefully in person. I insist, in fact, Bahadir, that you travel to Vienna. But if you cannot, someone in the audience, you may be able to attend in the hybrid situation. Thank you very much, and I'm happy to discuss any of that.